Good afternoon, everyone, and thank you so much for joining us for the third and final webinar in our READI Research Policy Impact webinar series for 2023. Today's topic is medical research as a tool for influencing public policy, and we're fortunate to have two local leaders with national reach who will share perspectives from their respective institutions and organizations. But before we begin, we'd like to share a bit about the CTSC. The Clinical and Translational Science Collaborative, or CTSC, of Northern Ohio is a collaborative among Case Western Reserve University and its affiliated hospital systems. The Cleveland Clinic, Metro Health, University Hospitals, and the Lewis Stokes Veterans Administration Medical Center, Northeast Ohio Medical University, and the University of Toledo. We aspire to be a catalyst for high-quality clinical and translational science and transformative research to positively impact the health of those in Northern Ohio and beyond. As we plan for the continued evolution of the CTSC, health equity takes center stage. A large body of evidence links social, economic, and environmental disadvantages to poor health outcomes, which are reflected in stark differences in life expectancy, infant mortality, and rates of chronic conditions like heart disease and cancer for residents of the different communities throughout our 9-county region. In the 2023 through 2030 grant cycle, our CTSC is focusing particularly on including the community in the process of clinical and translational research to better address health disparities and achieve equity. Without further ado, let's meet our presenters. Heidi Gartland is a healthcare executive, community leader, and health policy expert at University Hospitals, a $5.4 billion comprehensive health system with a national reputation for providing world-class healthcare, research, and education. Headquartered in Cleveland, UH serves over 1 million patients through a network of 21 hospitals, more than 50 health centers and outpatient facilities, and physician offices in more than 200 locations across 16 counties in Northern Ohio. She leads UH's strategy for community relations, community benefit, community health strategic investments, corporate reinvestment, strategic economic development projects, government and regulatory affairs, and diversity and inclusion commitments. She advocates for university hospitals at the federal, state, and local level and is a decorated government relations leader. Ms. Gartland's honors include election as a fellow of the American College of Healthcare Executives and as a board member of the American Leadership Council for Diversity in Healthcare. In 2023, the YWCA of Greater Cleveland honored Ms. Gartland as a Woman of Achievement. Previously, Ms. Gartland was recognized as a healthcare hero by Crain's Cleveland Business and was profiled for her advocacy leadership by Inside Business magazine. Ms. Gartland completed her undergraduate degree at the College of Wooster in Ohio. She earned a Master of Health Administration at The Ohio State University and a certificate in diversity management from Georgetown University. For over 7 years, Ms. Gartland served as an adjunct faculty member at Baldwin Wallace University, teaching health policy and law in the MBA program. Currently, she is an instructor for AHA's Certificate in Diversity Management. She is a regular speaker nationally and in Ohio on emerging health policy issues. Welcome, Ms. Gartland. And then we have Nazleen Bharmal. She is the Associate Chief of Community Health and Partnerships for Cleveland Clinic Community Care and Population Health. In this role, she works with an interdisciplinary team to implement a community health strategy for Cleveland Clinic, focused on health equity, social determinants of health, and partnerships with community stakeholders. Dr. Bharmal practices primary care internal medicine focused on disease prevention and health promotion. She previously was the Director of Science and Policy at the Office of the Surgeon General in the U.S. Department of Health and Human Services. Prior to her time at OSG, she was a clinician investigator at the Rand Institute in UCLA Department of Medicine, Division of Health Services and General Internal Medicine, with a research focus on health disparities, chronic disease prevention, and social determinants of health using quantitative, qualitative, and community-based participatory research methods. She has published in several scientific journals and received awards for her public health research and leadership activities. She received her MD from Harvard Medical School, PhD in Health Policy and Management from the UCLA Fielding School of Public Health, and Master's in Public Policy from the John F. Kennedy School of Government. Thank you both so much for being here. And now I will cue your presentation, Heidi. One moment, please.
Thank you. Well, appreciate the opportunity to be here today as Giselle is putting up the presentation. I know that we're talking about a couple of questions, and if you want to go to my first slide after this, there are a number of questions that we're being asked to speak to. How research priorities are determined at UH, and I'm so glad Dr. McComsey is here because she can also chime in there. How does UH use research to influence public policy? How researchers leverage partnerships with government and community relations departments? And what are some of the research opportunities driven by community benefit investments? And lastly, what diversity, equity, inclusion, and accessibility means for our programs? So if you want to move to the next slide and then advance one more, because I just went over that. So I'm just going to sort of go through. I know that Giselle asked me to speak for about 10 minutes, so I don't want to take too much time. Really looking forward to any comments or questions after Dr. Bharmal speaks. But you know, really how research priorities are determined at UH is really through our research leaders. There's not sort of a forethought at UH to say to a researcher, you must do this or that. But I would say because University Hospitals is such a community-based provider of care to the citizens of Greater Cleveland, that our folks that we bring to University Hospitals to do research are very enamored and very instrumental based on the population of patients that they see, to really dive deep into research priorities, especially in health services research, that really does provide information on best practice of care, interventions that really deal with some of those upstream social determinants of health. And so I'm really excited that I often have researchers and clinical leaders that come to me with their sort of questions and interests, and we're able to really think through how might they begin thinking about collaborations in the community to really do the best practice health services research. So I'm going to speak to health services research more than just, you know, sort of the bench research that we do at University Hospitals, because that's really, from at least my perspective as a government relations and community relations person, that's where that intersection is most palpable and most powerful. And I have a couple of examples of some of our clinicians just in the recent past. And I worked at University Hospitals. One thing that Giselle didn't say, I've been there for almost 30 years. In December, I will enter my 30th year, which is kind of breathtaking. And the other thing that I will say is, you know, I was at a 1 zip code hospital when I started, and now we are in 21 hospitals across 17 counties and serve really, you know, the top half of Ohio, which is pretty amazing from my perspective to have watched our system really enjoy the collaboration of health systems joining our team. And so here are a couple examples of things where our funding interests and our clinical leaders are really impacting some of those social determinants of health that many of us care about. If you think about redlining, Dr. Sanjay Rajagopalan, who is one of our amazing heart doctors at our Harrington Heart and Vascular Institute. That's what I know, we're terrible. I shouldn't put HHVI, but Harrington Heart and Vascular Institute. And he has an immense focus on so many things, particularly the impact of redlining. We all know that redlining was a matter of how loans were given out, but the impact of that sort of hard barrier for those that are under-resourced or have become under-resourced because there was underinvestment in certain areas, especially in the city of Cleveland. We're now seeing through his research the immense impact on health, whether that's the sort of deforestation of Cleveland and you know how we have so many blacktops and concrete instead of trees, providing that sort of protection for heat and air quality. The issues of cardiovascular disease being much higher in areas of redlining versus areas that don't have redlining. He's just recently come out with a paper on veterans and those impacts of our folks that, again, live within redlined communities. So again, the impact of being able to have researchers that have a sense of their own population that they're seeing every day coming in, and then being able to decode that and say, well, why is that? Why am I seeing so many African-American neighbors of Cleveland Medical Center coming in with heart disease, and where do they live? And why is it that folks that might not live in those same zip codes are seeing less from an epidemiological perspective? With that information, he also has an amazing collaboration through Case Western Reserve, University Hospitals on the ACHIEVE study, which is really looking at, again, this population within the city of Cleveland, specifically through the lens of housing security or insecurity through the Cleveland Municipal Housing Authority and Wayne State, again, studying interventions. So not just taking powerful information on epidemiology to know, okay, redlining makes a difference. Now let's go in and see how can we affect health-seeking behavior through non-traditional methods, and see if this something that we can learn that is not only going to help our own region, but nationally organizations. And with Wayne State, I think this will be a powerful study that will show how community health workers and really creating trust within a community that's very distrustful of healthcare for all the reasons of redlining and so many other things. So that gives you one example. Dr. Charles Macias is a pediatric doctor at Rainbow Babies and Children's Hospital. He is a head of our quality and the head of so many things. And he has a great interest in pediatric pandemic and disaster preparedness. And again, came to me and said, you know, listen, how can we partner? We were able to partner with him on a funding opportunity at the federal level through some language that we were able to get into some report language of appropriations bill. And he now leads a $58 million disaster preparedness network across America with some other organizations that are engaged with this. But the curiosity of this doctor, his stellar impact of saying, hey, kids in a pandemic are very different than adults. And just raising that issue and knowing that this needs to be something that the country should begin to look at. Again, it's going to benefit our region, but nationally, it's going to benefit all children across America as they come up with this health services research project in this particular area. Another example is Selena Kananen, who is our head of diversity, equity, inclusion, and belonging at University Hospitals as a nurse midwife by training, and has really partnered with our communities where we have 7 now Food for Life programs across our footprint, which really look at food insecurity. And again, the research that is now underway, we're not finally finished with that, but I think it will inform how do we take programs again upstream. If we have folks that are food insecure, how can we help them with their cardiovascular health? How can we help them with managing their diabetes and so many other things? That food is life, essentially. And so this Food for Life program, I think will provide a great learning laboratory, again, across our region that will inform, again, national information. Dr. Stephanie Teal is our chairwoman of our obstetrics and gynecology. And through our University Hospitals McDonald Women's Program, we run Centering Pregnancy. We have the largest Centering Pregnancy program in the country. We're one of their major hubs for this as a research-based intervention of group care for women. And again, the information that we're getting through research opportunities to look at how are we really impacting and bending that curve and that needle, not only on infant mortality, which this came really to the infant mortality crisis as a method to really engage and create trust and community amongst pregnant women in similar gestational periods. And what we found is that it also has an amazing impact on maternal mortality. So this is a program, again, evidence-based clinical programs that match our research priorities. Again, nobody went out and told these clinical leaders go do it, but their curiosity partnered with government and community relations has been just a real find. So if you want to go to our next slide. So the question here is, how does UH use research to influence public policy? I will tell you, number one, we don't do it alone. So anything I have down here is a collaboration with the Cleveland Clinic and Metro Health and many, many others across Ohio and the country to make these things happen. No one organization is going to be able to say, I did this. And that is not how community relations and community investment and community health works. It works in a neighborhood of many, many mothers and fathers of helping to figure out what should we do and then creating trust within a community together. So I look at Nazleen here and, we do this work together. So she may have the same list because we're doing this in collaboration. So UH influences this, but it is not UH's effect on its own. So back in 2014, of course, Ohio had a monumental moment after the Affordable Care Act passed for academics and for our advocates to come together and convince our legislature. I don't think it could have been done in today's environment in our legislature. So we had a magical moment of a Republican governor and a Republican House and I think a Republican Senate who passed expansion of Medicaid, which is unheard of in many. There are probably 7 or 8 states, maybe there's fewer than that, like Texas and Florida and a number of others that just are very resistant to expanding Medicaid to mostly single men and women between the ages of 18 and 64. And Ohio did it and it stuck. We know at that federal level, there's been attempts to get rid of the Affordable Care Act. I can honestly say I've not seen an attempt yet, and I knock on wood in Ohio that doesn't happen. But we know that there's about 800,000 people, but for this expansion of public policy really merging with research to show that uninsured people have much worse outcomes in health than people that have insurance. And you think about, I think about the families that would come to our emergency room that was their only place that they could get care prior to this. And now with a Medicaid card, they can go get their diabetes medication. They can go get their medicines and their physical therapy and all kinds of other things to keep them out of the hospital. And so in my tenure at University Hospitals, the Affordable Care Act and this particular expansion in Ohio are probably the most monumental that I can think of. Again, infant mortality and maternal mortality, without our researchers to come up with the staggering, sad statistics that we sit with in Northeast Ohio on our infant mortality and maternal mortality, we wouldn't be where we're at today with a collaboration, again, of all of the health systems, the city, the county, to really come around developing a methodology to collaborate again with community trust and organizations like Birthing Beautiful Communities and Pregnant with Possibilities and so many others that are out there that are working on this to drive down our infant mortality rate. And we are beginning to do that. I know the pandemic is probably not helping, so I know there might be a blip, but I know we've all been intently collaboratively as opposed to in silos working on these issues. And with that, I will say at the state level, the research to influence public policy was that pregnant women on Medicaid would have to leave Medicaid after, I think, 6 or 8 weeks after they delivered. And it's like, bye-bye, we'll see you next time you have a baby. And we know that 12-month continuous eligibility for new moms means that they not only can recover from their pregnancy, but they can think about spacing and continuing with all that they need to keep their women's health needs and their whole health needs as a front and center. So that, we know people that go to doctors themselves tend to take their children to doctors. It also is an inoculation to make sure that, that not only were they able to go to doctors, but they also brought their kids for all their well child visits. And so it's a great way. And Ohio was one of the first Republican states in the country after the Biden administration made this into legislation and policy. Violence prevention, again, going upstream, we have lots of work that has been done in the city of Cleveland. I don't think enough at all, but a little bit, that the city of Cleveland with some of their ARPA dollars has put into a violence prevention fund at the Cleveland Foundation. Again, I would say this is the most unfunded, most needed area that I think we all need to continue to advocate for. We see it at Rainbow Babies and Children's Hospital. We have the only level 1 pediatric and only level 1 adult trauma program in the city of Cleveland, and we are too busy with gun injuries. And we know the leading cause of death now for children is no longer motor vehicle accidents, but it is now gun violence, or I should say for young people, not just children, but young people, mostly men, sadly. And so this is an emerging area that for all of those on the phone today, we hope that you will work with Nazleen and myself and so many others that are committed to working on this issue. And this is not about First Amendment or Second Amendment, I get my amendments wrong, rights of taking guns away from people, but really creating an environment of prevention. Lead poisoning, again, which has been an entire community effort to reduce that. University Hospitals made an investment. I know the clinic had made a significant investment into this, in making our homes, we can take care of all the kids and do all the testing we want. I know the city has asked for all the pediatricians to do universal testing on all children up to age 2. University Hospitals did make a change for that earlier this year. The city is just, I think, sending notes out to everybody asking us to do this. But that's canary in the coal mine. We actually need to fix the housing stock. We need to not send kids back to homes that, either the owners or the landlords aren't updating and making their homes lead safe. So again, this is where our research can show it's terrible, but until we get public policy to catch up and change our housing stock, which was mostly built before 1970, I think 8, before they made lead paint, something that was illegal. We're going to have this issue until we fix it in Cleveland. If you want to go to my next slide. So how do they how do researchers leverage partnerships with government and community relations? I will say that both Nazleen and myself and others that work in the community and government space are always willing to take phone calls from any researcher that ever calls us anytime, 24/7, 365, because this is how we learn how to help you change public policy. You guys are public policy, probably interested people, and we're physician interested people. Now, Nazleen is both a physician and a public policy person, so she sits in a little bit different spot than I do. But it's really that collaboration of learning what your research interests and needs are, and how can we inform public policy to change the status quo. And that's literally what we do. We go in, we educate government officials, whether they're regulatory officials or whether they're legislative officials. And the best way to do that is to partner you as the leader in research to a public official. And it's, it's as simple as, having a relationship with them and sitting down with them. They're hungry to learn your information. We had I'll just give you an example of this. We had with our Rainbow Ahuja Center for Women and Children in Midtown, one of our biggest issues is utility shutoffs for our kids and their families. And it's one place where there's literally nothing. There's no public policy sort of source of funding like SNAP, which is for food insecurity, or Medicaid for health insecurity, or I'm trying to think of the housing insecurity. They have vouchers, and you can get housing for not just a week or a month, you can get it for a year. And yet if you get your utility shut off, there's no real public, because these are public utilities, so they're not really providing a lot of public resource to folks that have income insecurity. And so we, at a Rainbow briefing that we did for our Northeast Ohio delegation, a couple of our members got really interested in this, and we're now working on state legislation to really work on utility. It's an area outside, like I know nothing about the PUCO, which is the Public Utility Something Commission. And so we're going deep, we're figuring it out. Are there going to be public policy mechanisms? Because we know kids that go home to cold houses, or houses where they don't have the ability to, plug in their nebulizer because their electricity is off, are kids that are going to end up in our emergency department. And these are very preventable types of things. But again, speaking to public policy and leveraging those relationships make a big difference. We know how to, to decode that, like, how to speak of your research and your area of expertise. So please use us, please call us, and engage us, because we don't know anything until you teach us. Like, I always talk, I'm an awkward person that talks to people in the elevators and says, what is your research that you're working on? So I do kind of my own little internal research at the hospital whenever I'm walking the halls or in our lunchroom. But please seek us out. And then if you could go to the next slide. So opportunities driven by community benefit. I'm not going to get into what community benefit is. I will just say it's the floor, not the ceiling, for what hospitals that are not for profit have to do to keep our tax exempt status. So there are some federal requirements. Again, in the Affordable Care Act, we love it because it did a lot of things, not only provided health insurance to people, but it also put hospitals essentially in the square eye of the Internal Revenue Service, where you don't want to be, to make sure that you're actually justifying your tax exempt status. And you have to meet certain things. You have to do community needs assessments every 3 years. You have to decide how you're going to implement and work on some of those community needs. And you have to do specific things about how you bill people and collect from them, especially if they have no insurance. And so I won't get into the minute details of that, but it does drive us to understand what are the barriers. So if we're doing billing and collection practices and we know people don't have insurance, well, that helps us know that we need to figure out how to better do advocacy or access to these folks that might be eligible for Medicaid. We as a team do our needs assessments as a collaboration. This has grown over time. We now do this with the clinic and UH and Metro doesn't even have to do it. They're a public hospital, but by their good graces, they collaborate with us. We're not as many hospitals as we used to be. St. Vincent is no longer a hospital, but in each one of our counties, much like I'm sure at the clinic, each one of their counties, we collaborate with whatever hospitals that exist in those counties to do the needs assessments. And the needs assessments mostly focus on not just health issues, but what are those social drivers, social influencers. I don't really like social determinants of health because it sounds so absolute. I think that there's more influencers and determinants like housing and economic insecurity, environmental safety, transportation. So those are the things that we work on. And you can go on any not-for-profit hospital's website if you don't want to be in the bad eye of the IRS, and you should be able to find their community needs assessment, and you should be able to find their implementation plan. So it's a very easy thing to find and to plug into and collaborate with us. And if you want to go to, I think, my last slide, which is how do we work with diversity, equity, and inclusion, and what does that mean for our program? Well, our vision for community health and health equity is that is up there. This is, we just have recently developed our next strategic plan, our 2.0. And our vision is that we partner with our communities to provide excellent, compassionate care for everyone, and that everyone has a fair and just opportunity to obtain their highest level of health. And for us, diversity, equity, inclusion is not just about socioeconomic status, it's about your geography. We have Ashtabula County as an example where you may be 10 minutes or 10 miles from a hospital, but it might take you 10 hours because of, snowstorms and bad roads and, all kinds of other things. Digital equity is another area, religion. We have a lot of Amish in our community. Again, we focus really on disparities for race, ethnicity, gender, sexual orientation, and so much more. So it means a lot to us in terms of how we approach it. And again, appreciate the time. I hope I haven't taken too much, and I'll turn it over to Nazleen.
Thank you, Heidi.
So first of all, I want to say thank you to Heidi. She actually did a wonderful job, and I want to just say ditto on everything that she said. She's a wonderful partner for thinking about all the different questions about how government community relations can influence health policy and vice versa, how health policy can influence sort of medical research and how we think about diversity, equity, and inclusion. Similarly, our clinicians really do drive and our researchers drive what agendas that they focus on. I'm going to take a little bit of a different focus here, which is really thinking about medical research and population health as a health services researcher. So this will be a few specific examples. Go ahead to the next slide. So health systems, I just want to say, like, they confront a lot of pressures. So whether it's costs or it's like avoidable patient harms or disparities that we've talked about in health and healthcare based on race, geography, ethnicity, income, and just poor health outcomes. And I think for many of us, we think about how research can influence policy, but specifically health policy and health care. As a health services researcher by training, I think about it in these like 4 buckets. So identifying what is our place to identify critical problems that could be solved with policy solutions. Research that that shows the benefits and harms of a policy solution. There have been a number in Ohio. There's one on the ballot today, and how could that potentially influence things? The estimating the costs and the consequences of policy proposals, and then actively participating in the policy process. As Heidi so eloquently talked about, partnering with government relations to help with real-time decision-making. Locally, I have seen quite a bit. I've seen things around smoke-free institutions and tobacco-free places, clean air policies, and seeing that reducing smoking prevalence, still a long way to go in the city of Cleveland. I am personally have engaged with our government relations folks to provide testimony for the expansion and reimbursement of doula services for infant and maternal health, which we know is an evidence-based practice. Next slide. And so much of my talk is going to talk about population health. I suspect most of you are familiar with this, knowing that 20% of a population's health is determined by the clinical care it receives. The other factors do include your physical environment, where you live and what you're exposed to, health behaviors, and then the social and economic factors. And these factors are rooted in policies and programs that influence health outcomes. And it's a framework that really helps us think about where medical research can focus attention when thinking about population health. Next slide. So I like this example just to show an example of medical research driving policy change. So partnering with CBOs is a way to promote health of a population. The diabetes prevention program was a multi-center randomized controlled trial done in the late 90s, and it was a very multi-ethnic cohort. 45% of those participants were from racial and ethnic minorities. It had 3 arms: a lifestyle change arm, which was a lot of heavy, 150 minutes of exercise per week, and eating fewer calories, really nutrition and lifestyle focused with a health coach, taking a pill, metformin, 850 milligrams twice a day, or a placebo, just getting a placebo pill and getting nutrition and lifestyle sort of advice. And this was for adults who were at greater risk for diabetes, but did not have diabetes, so pre-diabetes. And what they found was that the lifestyle program was the most effective, even more effective than taking the pill at preventing diabetes. It reduced the incidence of diabetes by 58%. And if you're over 60, by 71% versus placebo. And even after 10 years, 34% of patients in the lifestyle program have sustained having lower incidence of type 2 diabetes versus placebo. And so the opportunity here was that the CDC then implemented the National Diabetes Prevention Program in 2010. And it went to, you could be a hospital, you could be a clinic, you could be a community-based organization. We have all 3 actually in Northeast Ohio, and the YMCA is a partner for Cleveland Clinic in the implementation of our lifestyle program. If we see a patient with prediabetes, we refer them to the year-long YMCA DPP program, and we share bidirectional data back and forth. What's more exciting is the policy change is its sustainability. It's covered by Medicare since 2018, Ohio Medicaid since 2022, and now some employer health insurances are including this as a covered benefit for patients who are pre-diabetic. So just again, another example where medical research drove public policy. Next slide. Just shifting gears again about Cleveland Clinic. So at Cleveland Clinic, we see 33.4 unique patients. We have 77,000 caregivers, 275 outpatient facilities, and 22 hospitals locally and worldwide. We have 4 care priorities: patients, caregivers, organization, and community. Next slide. And community has really been the brainchild of our CEO to identify this as a priority, much of it driven by recognizing the impact of social determinants of health, social drivers of health, I would say, on health. And so 3 areas that we're focused on at the CEO level is lead poisoning prevention, partially with our gift of $50 million to the Lead Safe Cleveland Coalition for safer housing through lead paint. The Center for Infant and Maternal Health, that's really focused on reducing the racial disparity in Cleveland around infant mortality, and then childhood hunger and nutrition security with our community partners. This is sort of an example of where you think about institutional policy that's been driven by SDOH research. Next slide. Just to put everyone on the same page, social drivers of health are much more institutional and systematic. They're the conditions in which people grow, play, live, and work, root causes of health issues, and they're shaped by a wider set of forces, including economics, social policies, and politics. Next slide. And that's in contrast to how we think about it often in healthcare systems, which are addressing health-related social needs. So health-related social needs, I often think of this as how individuals experience what they might be seeing from social drivers of health. So utilities, family and social support needs, interpersonal violence, transportation. We talked about food insecurity. Heidi mentioned a number of these, and these have been associated, we know, with higher prevalence of chronic disease and worse chronic disease management. They're also associated with 25% individuals with health-related social needs have a 25% higher 30-day readmission than those without it. And then addressing health-related social needs is associated with an 11% reduction in hospital costs. Give me 1 second. Next slide. And so we are seeing that there is just more and more hospitals have gotten really interested in social needs screening and action. And this has really led to more attention for screening, mainly universal screening. And so we have started to see increased attention and mandates. So for example, Healthy People 2030 and also 2020 started putting in thinking about, so Healthy People is the national framework of how about the health of the nation, started putting social determinants of health as one of the measures and thinking about how healthy the population is in the United States. We're also seeing the CMS, the Centers for Medicare and Medicaid, starting to mandate next year, all hospitalized patients get screened for social needs. And then the Joint Commission is also looking at social needs screening, as well as what action you're doing and what resources you're providing to patients. So one of the things that we started to look at was that this policy is key for medical research or health services research. Our team started to look at who is not responding to social needs screening. We did a retrospective study about 387,000 primary care patients who get screened annually. At least half of them had completed one question. And what we found is that the patients who were less likely to respond to these screenings, including patients on Medicare or Medicaid, those who are racial and ethnic minorities, and those who lived in higher ADI or higher disadvantage, more like higher disadvantaged neighborhoods, were less likely to respond to the screening. These are also the same patients that tend to have one or more social needs identified when you do screen them. So a big bias and a way for us to think about what are different models to help screen given these mandates. Is it just sort of a checkbox, or is there an opportunity for us as medical researchers and quality improvement specialists to think about who we're doing this in the name of equity? Next slide. Also, just to close the talk on social needs screening, there are a number of future opportunities I just want to lay out for medical researchers and specifically health services researchers. There is a partnership with CliniSync, which is Ohio's health information exchange, called Unite Ohio. All three systems, Metro, UH, Cleveland Clinic, are already part of the Unitus platform, which is an electronic platform that bidirectionally connects health organizations, including managed care organizations, human and social service organizations. And the idea is that you can send an electronic referral to a community-based organization if you identify a patient with a social need, and that community-based organization will then reach out to the patient to see if they can or cannot resolve this need. There's so many opportunities here. This can help us, this map shows where Unite Ohio is live. It can help us understand the prevalence and the prioritization of social needs in both our region and in the state. The impact of resolve needs, both on things that are important for our hospital association, but also for patients, for clinicians, how this is being implemented and what effects are they having, if any, on health equity, or could there be some unintended consequences about where needs are being resolved? Next slide, please. Another area of focus, it has been around food and nutrition insecurity, which we talk about as inconsistent access to enough food for an active and healthy life. The map on the left just shows where food insecurity most recently is most prevalent, which is pretty much, across the US. In Ohio, we see 1 in 9 people are food insecure, and in Cuyahoga, 1 in 8 individuals. It's even higher if you're a young person. It disproportionately impacts racial and ethnic minorities and those from socioeconomically disadvantaged populations. We know healthcare systems care much about this because it leads to greater risk and severity for chronic health conditions. Doesn't matter if you're a pregnant patient, a child, an adult, all of this affects your health. And then there are significant healthcare costs for individuals who are food insecure than those who are not. It's also a very modifiable and intervenable opportunity in many places. Next slide. And so recently the White House had a conference on nutrition, hunger and health. Cleveland Clinic was able to participate in that White House conference and talk with other healthcare systems about nutrition-focused interventions. We heard a little bit from Heidi about what UH is doing with their food clinics, and they're also screening patients. So are we screening patients and thinking about enrollment in SNAP, which is our Supplemental Nutrition Assistance Program, and how we can do that better, especially since the rollback from SNAP, from the federal emergency from COVID. We're also looking at prescription food clinics and medically tailored meals. And our most significant has been a partnership with the Meyer grocer to create this Meyer Fairfax market to eliminate a food desert outside of our main campus. This partnership has also allowed for there to be built housing above the market, which 30% will be affordable and for patients, for individuals who are low income, and also to work with our sustainability office to create green space and parks around the market. So thinking just holistically about what this means. Again, so many opportunities for medical research here to see how these are implemented. Do any of these programs help to improve nutrition security? Are those improvements sustainable? What does that implementation look like? There's a natural experiment clearly with the Meyer Fairfax market, and how does that look like in terms of addressing health equity? Next slide. And so just the main takeaways for me are just quality improvement and community benefit interventions, many of which I've just talked about today, are just really opportunities for implementation and evaluation research. We need more research in this area. People feel that they know what evidence-based programs are, but when it comes to implementing them in the real world settings, you need to think about how we're doing it and where fit and fidelity might fit in. And then co-designing the research and sharing our research findings with government relations and community stakeholders so that we can influence both institutional within our own institutions, but also larger health and public policy issues. Thank you.
Thank you so much, Nazleen. That was wonderful. Thank you so much, Heidi. So now the floor is open for questions from our participants and attendees. A lot of great calls to action there. I think if it helps, I'd be happy to kick off with a question that popped up. So I just drove past and did not know that that was the Meyer Fairfax market. That is absolutely incredible. You talked about sustainability, Nazleen. Can you speak a little bit more about that and what researchers should be thinking of when they're planning for sustainability?
Okay, so we often think about doing pilots, and I think pilots are wonderful and great. They can help us think about the feasibility of implementing. And so I'm going to talk about this from a community health intervention lens. So just to put that out there. But I would say where the opportunities for sustainability in healthcare tend to be are really around getting many of these programs as a covered benefit from health insurance, whether that be Medicare, Medicaid, commercial insurance, and just making it part and parcel of how we deliver healthcare, not separate from. So I think the more that we can think about that, the better. Same thing with reimbursement for community health workers, just ensuring that we have more of these opportunities, or doulas or other places where we know that these interventions can impact health equity and reduce health disparities. I will say that the more opportunities that there are for folks who are doing medical research to partner with government community relations to help communicate their findings to those who sit in the policy arena, the better. So.
Excellent, thank you. Heidi, maybe you could take this question first. When you think about dissemination and communicating with our legislators and those in our local government, you had mentioned reaching out to your office and getting paired up with someone. But when we think about some of the insights that Nazleen shared, how can we build a continuum of communication that's not necessarily sitting down one-on-one meetings? How do we maintain that presence on the radar in terms of our researchers and their research outcomes?
So it's a great question. I think number one is all the social media areas that we can make sure that, you know, politicians read, just like the rest of us do, what's trending on social media, or the print, if there are many of those left, or electronic media sources. I think that national publications, you know, we do a lot of work in our office to make sure we don't overwhelm our elected officials with too much information, but give them relevant information, invite them in to listen to our researchers when it makes sense for them. But you know, you need sort of the surround sound with them. You know, you need more than just us telling them. We have board members and community members that also know these elected officials. And I think much like the old day where you used to get their attention by writing lots of letters or having rallies, I think that the new day is, you know, the surround sound and having their trusted advisors also hear it. So it's not just about having the elected official, but knowing their staff, whether those are regulators or whether those are their staff of the elected official. Getting them on board is very important. And to change policy, it takes a village. I mean, you don't get doulas covered. It often is a marathon and not a sprint when it comes to changing public policy. And I can say that many people who want to change public policy get very dissuaded by the efforts that they have to put forward for there to be actual sustained change. And of course, you know, that is the way the political system works, is that inertia is the method. And in order to change inertia, you've got to get a lot of people speaking to the same issue. And then you've got to be able to address both sides of it. You know, even though we as researchers might know that something is really important, convincing an elected official to, as when I used to teach health policy, allocative policy is very different, because when I'm taking your dollar and giving it to somebody else, the deserving poor, convincing them, or the deserving whomever, you know, you're taking a dollar or power from one person and giving it to another. When you fund something like NIH, where everybody benefits, it's a much easier decision. So, you know, it's those divisive things where, like diabetes prevention, obviously it took a lot of time. Medicare figured it out long before Medicaid did. So, yeah, you know, and, you know, the one thing about federal Medicare policy is, you know, Medicare, they can deficit spend at the federal level, but at the state level, they cannot. So there are different sets of politics that go along with where you change the policy. Even talking about violence prevention, you know, again, at the local level, trying to get our folks to allocate, you know, $544 million worth of ARPA dollars, and 10 million of it went to violence prevention. You know, that's probably in the grand scheme of things wouldn't be our allocation if we were in charge. But again, those allocative policies of public policy are visceral, they're divisive, and the more people you can get in under the tent with you, the more likely you're able to get policy changed. And that's why it's a marathon and not a sprint. You don't often get something. Now, the pandemic was very different. They passed lots of legislation and waivers in the midst of a crisis, but in the midst of just regular living, things take a long time. And some people aren't cut out for waiting that amount of time. So it takes fortitude.
I couldn't agree more. I just want to say, I'm so glad you put it out. I don't know if anyone noticed, but it took 20 years for the diabetes program. And that was like lifestyle program. And I know there's a question, but I just wanted to ask very quick, Heidi, could you just speak about the role of stories? Because I sometimes think with medical researchers, they're focused on their data and their results and how stories could also be impactful.
Yes, so I'll give you two examples of the utility work that we did just recently. And one of our social workers that works on the barriers for our families at our Rainbow Hoosiah Center to being healthy, talked about a specific family that had their electricity turned off and a pregnant mom, and made it very personal. Gave it a name, gave it a face, gave it a location of where they lived. And it's very easy to be disenfranchised from the real need when you're just like a statistic. So again, researchers are great. We need those statistics, but those statistics don't tell really that personal story. And members, when they pass legislation, or regulators, when they change regulations, often are changing things because of a personal constituent story that they've heard, their own personal experience and passion. And numbers, it takes both. It takes the rigor of science and knowledge and the ability to be beyond reproach in terms of your numbers, and then able to go tell that story and put a face and a name and a passion around it. And so it does take both of us to get that done. We don't change policy without good data, and policy doesn't get changed without good stories. So it is both and.
All right, thank you. So the question in the chat is from Adam. How can D&I and implementation, focused evaluation, research, et cetera, be integrated with political realities, political and community values?
Okay, so I have a comment on this. Sometimes when we do D&I or implementation focused research, we are looking at sometimes just the impact on the individual. And if you do not take into context their family environment, their social and political environment, with new sort of methods of thinking about that, you may think that the intervention fails, but actually what is failing is where that person is either living or the policies that potentially structural racism that is affecting that person from actually engaging fully in your intervention. So I would really encourage D&I implementation and evaluation focused research to not just think about, again, individual level impact or change or thing at a person level, but take other techniques to think about all the factors that might be in that and put that into your research design.
Okay. Do we have any more questions? We do. Is there any research on the impact on health and care from patient digital engagement with healthcare?
I think.
I defer to you, Nazleen. You're
Oh,
the
I was gonna actually, I don't know if she wants me to call it out, but I see that, first of all, Amy, you might be able to talk about this. So I would say feel free to share your findings. And then I know that Elizabeth Will actually looked at a bunch of studies related to this as well. So go ahead, Amy.
You're on mute, Amy.
It really wasn't a loaded question other than to say that I think, the opportunities of patients to be digitally engaged, whether it's telehealth portals or remote monitoring, is so rich. And the great thing is you all capture every single click that a patient makes, so you don't have to do a survey and ask them, how many times did you X? And so I just think it's very rich for research. I was hoping you'd both have a long list.
I mean, I'll just say very quickly that I would say that, we're still, the word is still out on telehealth. I think we're still looking at things. Many people have enjoyed the opportunity because for patients that have transportation barriers and other things, it has increased utilization. So we're able to, I'll speak as a primary care doctor, able to see that and see where they're living and the context of their home. And that's very different than when they're coming into our house. Us being able to reach into their house, it's more powerful, but you got to have like affordable broadband and know how to use the equipment and know how to engage. And that in itself in this area has a whole host of issues. So I would say many opportunities to think about this for health broadly, quite frankly. Yeah.
One thing I will just say on that same note, in the world of COVID, there was a new program called Hospital at Home, and it is a program that allows hospitals, rather than admitting a patient from the emergency department, to essentially safely allow them to go home with all the sort of bells and whistles that a hospital would need to provide services that are equivalent to inpatient care, kind of the old day of the doctor coming on horse and buggy and taking care of you at your house and providing you. But there are a lot of digital barriers. We've gotten around that by providing patients that do not have access to broadband and things like that with specific technologies that then provide them with broadband and the ability to tether the digital equipment and iPads and the things that we leave them with back to the hospital. But again, if you look at digital access, those are both our brethren and sistren in rural Ohio, as well as inner city urban. So, and then we have a healthy at home program where we just provide digital access and an EMT that comes to visit them, which is a little bit of, it's not a billable DRG and patient service, but it's a next gen sort of technology that keeps people from maybe sitting in a observation unit at a hospital and able to have, their dog and their cat and their family with them while we're safely monitoring them. Again, we have digital access issues again in rural and urban areas. So, often people think it's just low income people in inner city. It's also rural America as well, and probably everything in between. So.
Thanks for your
Thank
question.
you.
And for our final question, could you advise on how to reach and engage the grassroots diverse populations who are understudied and underrepresented in clinical and policy research?
Okay, so this is like the question. Heidi, go ahead.
I was just going to say, Dr. McComsey has an amazing van that goes out and does that outreach in communities that wouldn't normally see us. So I'm going to let her talk about that because I think that is a novel way to increase our access to disadvantaged populations.
Hi, so first, thank you both. Actually, it was great to just listen to what you're doing, and there's so much happening at both hospitals, and I love to hear about collaborations. At UH, what we did to access rural populations as well as underserved populations, both underserved ethnicity, race, and so on. We convinced the hospital actually that to fund a research mobile unit. Basically, it's a huge bus that has everything you need to conduct a research visit, from freezers, centrifuges, bed, table, everything you need, TVs even. So we did that, and we were using it for one, large study, for example, Recover. And I can tell you that people love it. They come even when we're at Illyria. Not only it helped us to get rural communities and underserved communities, people love it. They come to the unit and say, what is this? Just passing by, what are you doing? And I go, research. It's like something that they never thought about. First time the word research, like, oh, tell me what you're doing. And this is why for Recover, UH actually is the #2 in enrollment in the country, because really the mobile unit helped us a lot. And the idea is simple: go to where patients are, right, where the community is, and talk to them, educate them about research, and they will do it. So even people who are very skeptical about research, if you make it easy for them, go to where they are, explain what you're going to do, educate them. Why is it important to have Hispanics, African American in a study like this? You don't want to be left out. You don't want to be the population that we don't know if long COVID happened more or less. What are the risk factors for your population? So it takes a lot of education, but going to where people are really made a big difference. And people love it. Even staff love to be on the bus. Like when they get the assignment, the bus, it's like a good day for them.
Thank you so much. I know we're at time, but I think that's, I couldn't just echo the same point to go, you have to get out of the four walls and go into the community. But I would say it really helps if you have a trusted community partner and you're not the one doing all the talking. In fact, you should not talk and let the partner do it for you. I'm a huge believer that I'm all about community-based participatory research, that anything we do should be co-designed and co-led with the community and end user in mind. I think it is much more effective. It's much more applied. You don't have to ask questions later. You can share. So if you can have a community advisory board, but again, to build that trust, you need a partner. And that partner is critical to help you get into places where you might not be able to get into. So just think about that. And I think, again, working with your community relations team and government relations team can be super helpful because that's their bread and butter.
Yeah, nicely said, Nazleen. So the CTSC, as Jalise knows, because she helped in creating the CAP. So we have a new community advisory board. I know, Nazleen, you're involved in the CTSC, so I'm happy about that. And as you said, we want to make the community kind of, proactively engage, because usually what happens is it's like you talk to them at the end, right, of every study. Here we want them on the table, designing the study with us, giving us their opinion ahead before we start doing the study and come up with results. So you're right, you're exactly correct. We need the community to partner with academia to really improve the health of everybody.
Thank you so much, Nazleen, Heidi, and Dr. McComsey. And very quickly, we will close with what's next. We have a READI Research Policy Impact Workshop next Wednesday, August 16th from 10 a.m. through 2 p.m. And that'll be held at the Bay Village branch of Cuyahoga County Public Library. Registration is still open. Lunch will be provided. CME and CREC is available for participants. We'll hear from Dr. David Margolius, Director of the Cleveland Department of Public Health, about local health policy. Stephanie Anderson, she's the Manager of Research Translation at Washington University in St. Louis, and she'll talk about the Translational Science Benefits Model. We'll hear from Dr. Edward Barksdale, Division Chief of Pediatric Surgery at University Hospitals Rainbow Babies and Children's Hospital. He'll be speaking about the Anti-Fragility Initiative. And we'll close our programming with Ken Surratt, Vice President of Community Investment and Chief Investment Officer at the United Way of Greater Cleveland, and he'll be speaking about the social determinants of work. So please join us in person if you are available. What can you do today? You can schedule a READI consultation at spark.case.edu, sign up to attend future programming and join our listserv, and review CTSC DEIA resources on our website. Thank you so much for joining us and have a fantastic afternoon.